Hey, everybody. Good afternoon. Today is, as you know, we are doing our World AIDS Day conversations. Earlier, we did a conversation around women. And today, now we're going to move into a conversation about the thing that I'm probably most passionate about these days, which is the impact of the syndemic. And that's, in this case, HIV, viral hepatitis, and substance use disorder on rural communities. In Appalachia, mainly, because you know it's what I care about, but also just in rural America as a whole. I've got two of my friends here, and two of my other friends are stuck somewhere in the ether trying to get in here. So I'm going to introduce them to you first, and then we're going to start having a bit of a conversation. Eric, do you want to tell the people who you are, where you are, and what do you do?
Sure. I'm Eric Ridings. I'm a pharmacist by training and currently work for the Department of Public Health in South Carolina as a behavioral health initiative program coordinator. Live in Spartanburg, South Carolina, and cover all of the upstate region in South Carolina.
All right. And then who else? Zill.
Yep.
Is your middle name really Joyce?
So it's actually my last name. Joyce Dixon Romero is my last name.
Okay.
Just as the front there. But yeah, hi everybody. My name is Zil Joyce Dixon Romero. I'm the State Government Affairs Manager here at the National Rural Health Association. In that capacity, my role is to sort of look at and analyze state legislation and jump up to the federal kind of policy realm as needed. I'm excited to engage on some of these topics today and really get diving into the meat of what's going on in the world.
I mean, I don't know if we got time to do that, but
we're gonna make time. We're gonna make time.
But we're gonna talk about a few things. I don't know if we've got time to get into the meat of what's going on in the world. One of the things that is yesterday was World AIDS Day, and I think it was like the 40th or the 42nd, and many people don't know or are unaware of the role that HIV is playing in rural communities, primarily because of the Oxycontin crisis. Now, Neil, you've heard this thing 1,000 times, but I'm going to do it again. I'm going to talk about this train. And Eric, this might be your first time, but this won't be your last time probably hearing this either. What I like to say is this, that there's a train roaring through the Appalachia region. The engine of that train is the Oxycontin crisis that we know. The next car on that train is hepatitis C, hepatitis B, Hep A, educational attainment challenges, economic development challenges, workforce development challenges, with the caboose of that train being HIV, and with the sidecar syphilis. Particularly in the West Virginia region, I say we need to imagine that train laden with coal. The environmental impact of coal, the economic impact of coal, and the psychological impact of lost coal jobs. And I think that one of the things that we've got to figure out is how we address each one of those cars on that train, and how we do it together. But most importantly, how we begin to have a conversation about what are the role, particularly around behavioral health providers, in my opinion, because I believe that if we look at the 20 to 25% of HIV cases we say we can't find in the United States of America, and roughly 40% of hepatitis C cases that we say we can't find, I think they're sitting right in MAC clinics. And for those of you that are joining us that don't know what those are, a MAC clinic is a medically assisted treatment provider clinic. That's where you get buprenorphine, Suboxone, methadone. You get those opportunities there. And so what we want to do is kind of talk today about the impact of HIV and substance use disorder in rural America. But what are some of our responses going to be? We want to talk a bit about what we're going to do with some of this opioid settlement money that's coming. We're going to talk about, can we get community health workers in every state? Maybe that'll help us. We're going to talk about a whole bunch of things. But most importantly, I want to know, Eric, from you, because I always talk to Zeal. I know he's going to tell me, that he loves me and that everything. But Eric, tell me what you're doing and what you see, particularly around behavioral health, because you're in the behavioral health department, right? So I think behavioral health
Right.
providers have a very specific role. Can you talk to me particularly about this MAC clinics and other providers, their response to HIV and Hep C?
Right. So, in our work currently, we're still assessing quite a bit of what our uh, go forward is.
Uh-oh. Did you freeze
And I'm
there,
having some
Eric?
connectivity issues. Sorry.
All right. Just go slow. Just go slow till you know, is what I say.
Yeah, so hopefully that's better now. But we're assessing what's going on in our region. Particularly, we're working with our community partners. A lot of them are running MAT clinics, and we're looking to see where we can assist. A lot of what we're doing today is already partnering with those groups, and also we're doing a lot around uh, drug take back day, save a life day, that sort of thing, as far as where we're getting started. But right now we're still, with this being a new team just started in July, we're still doing a lot of assessments on where we're needed to help the various groups in our region.
And so I hear you, Eric, that you are just starting with your team. But what are the did your what are the goals of your team? What are the mission of this new behavioral health
Yeah,
department?
so our goals are based on a grant that we had through last year that was focused on reducing stigma in substance use disorder. So we want to expand on that. We have a good program that was um, more focused on healthcare providers and reducing stigma. So we're going to be pushing that out more as we move forward over the next couple of years on our 2 year plan that we've developed. Also, we've done suicide prevention training, and we're working on a program there to go along with our health department employees to get them all trained. Uh, Overdose prevention. We're looking at various ways that we can affect that, and harm reduction in general. And I know in South Carolina, there's a syringe service program bill that was proposed over the last couple of years, and we're watching to see if we can get that back out there in 2025 when our 2 year session starts back. So we're working with some partners that are pushing forward with that, especially the South Carolina Harm Reduction Association
And so
or Coalition.
So, Eric, let me ask you this: so, are you seeing an increase in cases around folks who have lived substance use disorder experience? Is that going up? Is it coming down? And are those groups, particularly? I'm really kind of focusing on these MAT providers because I feel like we've left them out of our HIV and Hep C response. Are they testing for HIV in most of your MAT centers there?
They're not necessarily, but we are. We have mobile clinics that go out from the health departments that do the mobile testing, and they're testing for HIV and STIs in general. So we have a whole community engagement team, a DIS team that does that, and we're partnering with them some on that, trying to get. They're adding Narcan to their ability to give that out at some of their clinics, their mobile clinics. So that's a new thing for us. We've not done that in the past, so that's something that started really in the last couple of months. So that will be expanding also, but I don't know that we're seeing an increase, but I don't see that we're seeing a decrease in SUD. I was looking at some new reports that came out. I think it's called the dose report from CDC, and it actually showed a couple of our counties that are very rural that are seeing an increase in non-fatal overdoses. And we're actually today, I've been working on that a little bit on how we approach those communities and how we partner with them and the current coalitions on moving forward to help reduce that.
Okay, very good. Now, Zil, you are out in all of the rural communities all over the place. What are you seeing for, especially like in rural health departments, rural federally qualified health centers, rural health clinics. Are you seeing an uptick in HIV? But also tell the people what it is that you do and the National Rural Health Association is doing around the syndemic of HIV, viral hepatitis, and substance use disorder.
Sure. Well, let me start with the second question. And so, for the folks that don't know, the National Rural Health Association's a 21,000 plus membership organization that spans all 50 states and a couple of the territories too, with the intended goal of kind of elevating the conversation around rural healthcare. And that spans a broad spectrum, right? And so, over these past couple of weeks, National Rural Health Day was 2 Thursdays ago. And so, in partnership with that, with the National State Offices of Rural Health, NRHA went and traveled to a lot of rural communities and got to be engaged in these conversations around what's happening on the ground, what we're seeing, what's being upticked, what's being talked about. And the big thing that we've been hearing a lot of is trust.
Mm.
Being able to build trust with these rural communities that at time has felt somewhat ostracized, especially in the battles around health coverage in recent decades. Not just the past couple of years, the past couple of decades. And so there's a struggle around worsening health outcomes, plagued with medical debt, confusion about, if their hospital or if their clinic, their RHC, FQHC is even going to be around in a few years. We've seen since 2010, hundreds of these rural facilities closing across the country. And so, when you ask that question about what's being seen, what's being talked about, a lot of times it focuses right in on workforce. It focuses on the addressing the issues that are happening in the community. And even if we can get workforce to come tackle these syndemic issues, right? It's going back into the communities and saying, we need to build trust with you. We need to hear what your concerns are and why these issues are happening. And then let's talk about a community-oriented solution. And so, we are seeing in various different regions, specifically in Appalachia, some of those numbers are increasing. They are, and it's just a partnership. It's community education work, which a lot of great organizations, just like yours, Tony, is doing and trying to build up that education factor. I got to say, there was a part of my journey in these past couple of weeks where I drove through West Virginia into Tennessee, and I saw a lot of, open billboards, advertisements from local community hospitals, community education groups, individuals that were just, trying to get information out there about syphilis and HIV and ways that you can seek treatment and help in your local community at a reduced rate. And so I think there's a two-pronged approach that we have to really be talking about, right? There's the policy approach, where we are going out Capitol Hill, your state legislators, your local and county health officials, and advocating for that need to bring either more money or realistically better community-oriented solutions to the communities and bring that and elevate that up to the federal and state level. And the second is building off of that work that we're doing in the advocacy space and doing it in the community engagement space and say, all right, well, our lawmakers are aware of the issue, but what community programs are helping? Why is this county have lower rates than the one next to it? Is it because of the people? Is it because there's an FQHC that's really helping on the ground? Is it their local community health office is more engaged with the community, working with schools and churches and getting sort of that engagement going? What's the solution? Where is it happening? And so I think kind of broad stroke speaking, it's kind of got to be that two-pronged approach where you're getting help from institutions, but building trust in the communities that these institutions are helping you in ways not that we're from Washington and we're here to help. We've heard your concerns and we want to make sure we're putting solutions in your hands to help these rural towns and these rural counties.
Right. Thanks. And now Dr. Kilkenny has joined us, and I know he's not new to this. He's true to this. And it's been a while since I've seen you, Dr. K. And I think that maybe you thought, like, what are they talking about? And so what I'm talking about in the question here today is we are in honor of World AIDS Day, which was yesterday. I wanted to have a conversation about the syndemic approach and particularly how it's impacting rural communities. I know that you were one of the first people in West Virginia to really design and develop a PrEP strategy that was really a successful one. I think you started talking about prep before other people started talking about prep. I don't know. We lost Eric. We get you and we lose Eric. It's like a round robin around here. So first of all, introduce yourself to the people because they don't know you. I know you and love you, but they don't know you and love you. They will by the time this call is over with. Tell them who you are. Tell them about your prep strategy. Tell them what you're doing for World AIDS Day, and tell them how you're fighting the syndemic. And then I'm going to talk to you about MAT clinics.
Okay, I'm Michael Kilkenny. I am the CEO and health officer of the Cabell Huntington Health Department in Huntington, West Virginia. We have been addressing issues around overdose, substance use disorder, and HIV and this at probably really aggressively since 2015, and so what we've been seeing is remarkable a remarkable improvement in our well, our ability, certainly our knowledge base, because we were a low HIV incidence community prior to 2018, and so we've increased our knowledge base, but we've increased training for providers in the community at the Marshall University School of Medicine, use disorder, making sure that we're offering care that isn't intimidating or that.
Dr. Kilkenny, I feel like we're losing you. I feel like we're losing you.
Okay, I'm not sure that I have any control over that.
Now, I think if you lean in, maybe you whatever you just did was perfect perfect pitch, as they say in musicals.
Whatever we just did is what we'll try to do again. We were
Right.
talking about training that we've done with the medical community. Not only we did a lot of training with the existing medical community, but training the newer doctors has been amazing over the last 10 years to watch the understanding of substance use disorder, that kind of destigmatizing of it, the more willingness to engage with people in conversation rather than with judgment, and we're seeing a tremendous improvement in the way people are perceived and the care they receive as they interact with the healthcare industry. We did a lot of work when we had our HIV outbreak, which was 2018, 2019. I can report at this time that we are on track to have fewer new cases of HIV in 2024 than we had in 2018. So I think we've made a lot of progress. We're not approaching yet quite our goal of 0 new cases, but we're making tremendous progress, and we've done that largely through collaboration. Huge changes in the ability to provide care for HIV, provide PrEP in the primary care setting. Our largest FQHC has made big strides in that. I wish that I could say that we have a great PrEP uptake. We did a lot of work to expand its availability. We've done a lot of work in getting more and more providers offering it. The uptake remains low. I think that's a national problem, and I'm not sure how to solve that. But I think further destigmatization is going to be what we really have to do. And I'm not sure where else to go with the question that you've just
No,
asked
no,
me.
no. Yeah, you landed the plane right where I needed it to be, and I'm about to walk off. I'll walk off that plane with a couple of other things. So, one of the things that I believe is that we've got approximately, they say 20 to 25% of HIV cases in the United States of America that we can't find, is what they say. They say roughly 40% of hepatitis C cases, they say we can't find. I think that they're sitting in MAC clinics, buprenorphine, Suboxone, and methadone, to one lesser or greater extent, either the individual coming into those facilities, social, sexual, or drug sharing network of the individual coming into those facilities. Let's have a conversation a bit about how important is it, or do you think it's important that we start to bring in those MAP providers to ensure that there's screening for HIV and hepatitis? And also, do we see the opportunity, if they don't, to increase their willingness to do it? Screen for HIV, make it mandatory, make it routine. Is it that we should be talking to them in a different way? Because Dr. Kilkenny, I agree with you. I think that one of the issues is, and I've been talking about this a lot with both pharmaceutical companies and some other companies that are offering either free PrEP or others, but and also our federal partners, of saying, I think that we do a bad job of telling Johnny in Grant County that he is an actual candidate for PrEP. If I look at the advertisement, if I look at much of the printed material, if I go to some of the websites, Johnny doesn't see himself there. Mary doesn't see herself there. And if we don't create the opportunity for an on ramp for them, then of course, if I don't see myself there, I'm not going to think that this product's for me. And if we're at a point in, I believe, our HIV response where we've got Cabenuva, you can take 2 shots, 4 shots. You've got lenacapavir, a new treatment coming on the market. That's 2 shots, and you can either treat it or you can prevent it with this kind of simplistic method. But if Johnny and Jane and Mary Jane don't see themselves there, what's that? I mean, so is that just an access issue? Is that a stigma issue? But most importantly, how do we bring these MAP providers into this fight? And I'm going to go with you, Zil, because you're sitting there looking like you're very smart. So I want a smart answer.
What can I say? I have a very discerning look, when you've got the gears turning in the back of my head there. Well, I think a couple of things. You really hit the nail on the head when you were talking a little bit about, I need to see myself there so that then I feel comfortable going, right? And it's around that stigmatization issue. I think that's a big thing, especially in rural communities, right? Where we know the CDC data is out there, that tens of new thousands of cases are confirmed every single year, but there are rapid response rates now. You've got things, but then it goes back to, well, I don't want to be the person that's getting talked about at my local X thing. But that's why right now there is this engagement factor that's out there, right? There's billboards about syphilis information happening in Appalachia. There is new drugs that are on the market that can help combat these issues. But it's also about getting that level and jump from, is it a rapid response care or is it a preventative measure? And how do we intersect those two? Getting the MAP providers out there in the communities is obviously critical because we need the workforce to administer the responses that are necessary. But it comes back to, what are those MAP providers doing, right? Is it improving a facility? Is it ensuring that they're, responsible and in a specific spot that someone can go to? And also, are we improving outpatient facility treatments? Is it just something that we're just seeing at clinics? These are a lot of questions that have to be answered. But I think the core of it starts with, we've got the treatment options. They exist. We need to make sure that people can feel that they can be seen places, and not just feel like they can be, actually be seen places. And 3 is be able to respond to them in a way that is not patronizing and stigmatizing, but respond to them by saying, no, this is for your health, and it's not just you, and you're not alone in this journey, and I think that is sort of saying, you're not alone. It's okay, but we have options. You just have to come see us.
Yeah, no, I there, like I said, there are a couple of websites that are supposed to give away free prep or prep access, and I go to them and I say I can't put this thing out in
Right.
half of our community partners. They're gonna look at me and say, "Have you lost your mind?" I mean, they already know I'm a little off, but they're gonna really think I'm crazy.
Right.
I'm like, if I send them this. Eric, are you seeing any kind of challenges or access point issues that people maybe not seeing themselves as a part of the HIV solution out there, or what are you seeing?
Yeah, I think part of it is just the knowledge. Folks don't know what's out there. And that's some of what we're doing with some of our partners is trying to get the word out. We obviously do some free testing at the health departments on special days. I think there may be one this week, and along with World AIDS Day this week. But there are various things like that are available, and just getting that word out is a little difficult, and reaching the right people.
Mm-hmm. Mm-hmm. Dr. Kilkenny, what about you? I know we kind of started here, and I'm coming back to you now. Is there a messaging campaign that you're doing, or that you've seen that you think might work, or that we can do to so that people can see themselves as a part of this? And what can we do with companies to make the companies change too? Because that's a part. I mean, they spend a lot on advertising, and they don't necessarily see our communities as a part of their solutions.
Yeah, we haven't. We didn't really do an effectiveness study of our ad campaigns when we were really working hard on getting screening up. We put ads everywhere. We put them on the gas pumps. You're right that we have to put those models that appear in those ads have to look like the people who need to get the service in our community, as opposed to what we know the national statistics are in our community. We need those to be straight white people, and uh, so I think that we do need to do a better job in getting the messages out. We have been able to do some of that, but a lot of that has to do with what kind of resources were we given. When we had a major outbreak, we got all kinds of help. We got all kinds of resources. We have testing skills. We can do opt-out testing. I prefer opt-out to mandatory. Well, we don't think mandatory is a legally viable concept for testing, but opt out works really good in our community in making sure that it's really very low barrier available to somebody, such that we're actually going to do it unless you tell us not to. And we've been able to get a lot of help in partnership with the MAT providers, uh, with the hospitals, with the primary care doctors, getting people, screening folks, and doing that just kind of more across the board, more in line um, with basic screening recommendations than with the stigma of a pre-screening set of questions, although our emergency rooms will still do that, do a three-question uh, set that then alerts them to a higher risk of substance use disorder. We've got a lot of things going on. We just can't seem, from a policy and payer side, we haven't been able to get out of our own way. Our legislature has made harm reduction much more restricted. It's much harder for somebody to receive harm reduction services in West Virginia, anyway. Um, And then the payers in West Virginia still require additional hoops to jump through to get your PrEP treatment or to get for your hepatitis C or to get your HIV treatment, even though primary care providers have that ability. It's not as easy as writing a prescription and getting a person their drug right now. It takes longer to get the drug through those systems than it does to get them an appointment with a provider nowadays. And those delays are just deadly to folks. So I think that a lot of things that we can do, uh, but uh, some of them are a bit above our pay grade. We need to keep advocating for those changes in policies.
Well, give me some of the things that you think we can do. Because here's the thing that's funny. You want it funny? Ha ha ha. This and not so funny is that an hour ago I had one of these conversations about Black women or women of color in the United States, and guess what? The argument was the same. They don't see themselves in the ads. They don't see themselves in the response. They find that the big issue that came out of that conversation was an issue of access, treatment access, access to information that where they saw themselves in everything from the advertising, but also in the actual response. And that's one of the things, I've kind of really worked over the last few years is to for getting everything from Appalachia into the national AIDS strategy to being able to say it's important that we have a rural director. And I think, the National Rural Health Association was a big pusher of this one. Is not pusher. Hey, I know we're talking about harm reduction. I didn't mean it that way, people. But real advocate for ensuring that there was an office on rural health at CDC, because there hadn't been one. There was one on the HRSA side. For folks that are maybe watching that don't know, HRSA provides more treatment and care related outcomes, whereas CDC talks about prevention. If we've got the largest prevention agency in the country not promoting rural health or defending rural health or supporting rural health, there's a problem. And so, I think making sure that that's a priority. But I come back to, what's the solution? What do we do?
And if I may just jump in here a little bit, if that's all right, first of all, NRHA is very proud of the fact that the CDC now has an Office of Rural Health, and Dr. Diane Hall, who is leading things over there, is doing a phenomenal job in trying to find data points that can lead us to solutions, right? And that is exactly what we have been striving for, is finding good data that helps us inform good solutions. And I don't know if I don't have the answers. I know I don't. I know that I have seen pockets of good information. I've seen pockets of good solutions, and we try to elevate them when we can. But the big question is, what do we do to fix the issue? And I think the answer is having conversations like these and then using it to inform policy. Because I don't think there's one solution. I think there's many, and then getting those all together to inform the right policy is the answer forward. And maybe that's a little bit of a cop out here where it's just, there's not one solution, but there isn't. There is community-based solutions that are happening in different counties in different states that are probably not going to be the same perfect uniform model nationwide. But I can say, at least for the Appalachian region, it's all about getting more people on the ground who look like you, sound like you, and are willing to administer the treatments that are necessary, and growing those grow your own models to then return people back to their communities to help engage. And so we've seen a lot of great information, a lot of great programs coming out of that. Hopefully CDC will have some more information and maybe some grants in the future, but the CDC Office of Rural Health is a great place to start for now.
And so, Eric, let me ask you this. With everything that we kind of see with HIV, hepatitis, substance use disorder, what's the role? And I'm not picking on you, Eric. I know Eric is like, well, listen, lady, I just started, the department just started like 2 weeks ago. Leave me alone already. But here's my question for you. for all three of you actually, what's the role that opioid settlement funds play in maybe helping us with some of these solutions? Is it, does it? And I got a couple of theories around that too, but you know me, I got theory about just about everything.
Yeah, I think it's huge. Several of the groups that I'm involved with most recently are actually still trying to figure out how to use those funds and how to use them best. And a lot of that is focused on really how do we reach groups and how do we actually grasp those funds in order to reach those groups. So there's a lot of work going on around that in South Carolina, and I don't know if it's different in other states, but from what I'm learning, um, it's not necessarily as easy as you would think to get those funds. And a lot of the communities that I'm working in are still sort of working around the hurdles that they're seeing getting the funds and then deciding how they're going to use them best. So there's definitely a huge role that those funds can play, and uh, again, some of the entities are just struggling to figure out how to best use them. I'm on several advisory committees that are trying to help various fire departments, nonprofits, what have you, that have some ideas, but then they've got to put that to paper and be able to actually get those funds in order to do the work that they see is needed in local communities. But I agree that it's totally about that community engagement, and having peers out there that know what's going on and know the folks that are involved and to get them the assistance they need.
Dr. Kilkenny, what do you say about opioid settlement funds playing a role here?
I think that's a really good suggestion and something that we probably need to focus better on. It will take opioid settlement funds for us to get the kind of communication penetration that you're talking about, because we're going to have to not just do TV, we're going to have to do social media targeted um, advertising and issues along those lines that take a those are all understood by people who are very skilled in communications, but that costs money. Most rural communities are not going to do that individually because we aren't, we, we might be ignorant of those things, for one thing, or we may not be able to get that kind of money. So I think we're going to have to work in coalitions or larger agency in order to accomplish that.
Zil?
I'm on mute there. There we go. I think that this is just an area that, that we see, at least on the federal side, as hopefully having positive ramifications. But just as sort of the national state guy, I'm going to leave it up to what these two have come up with so far.
Well, yeah, okay. Well, listen, you walking on some soft leather shoes there, my friend. I'm like, I mean,
you're not gonna let me off that easy. I know.
I'm not at all, because number one, we've got a link to our opioid settlement newsletter, shameless plug, which we and Eric will make sure you get it, and you give it to all of those community members, because we have some tools in there for them to use and that sort of thing. We can help them with grant writing and all that kind of stuff, but don't worry about that today. Yes. So, but here's the thing. I think that this is a harder conversation, right? Because one of the things that we're looking at now is, one of the things that kind of started this whole kerfuffle, right, was the CDC's 220 most vulnerable counties in the United States, right? When you pulled those counties out, right? Again, when you looked at the first tranche of those counties, 28 of West Virginia's 55 counties were on that list.
Yeah.
And then the next thing that happened is, I think it was probably within a year to 18 months of that MMWR coming out, Morbidity and Mortality Weekly Report coming out, that the next thing we saw, and Dr. Kilkenny, and you'll say, no, you're wrong, you're wrong. Correct me if I am, but the next thing that we saw come out was that West Virginia health alert about it was either 3 or 4 cases in the southern part of the state. And then the next thing we saw was, well, wait a minute, those weren't necessarily men who have sex with men cases, but when we got it, that we were probably having a outbreak, or because they use molecular surveillance, that we were having a cluster break, which was really cases associated with harm reduction. Now, if we've got 423 counties in Appalachia, and most of them are seeing some sort of harm being done to them by the opioid crisis, how is it that that opioid settlement money doesn't belong to those counties and belong to the organizations and the people in those hills and those hollers? That's the thing I keep trying to figure out. And I keep trying to figure out why we're not saying it, doing it, and going out and shaking them by the collar and saying, give us our money. Dr. Kilkenny, to you.
Well, we tried to do that with our community, and the judge basically said we lost that suit. And the money that we're talking about, our community sued for $1 billion. That's enough for our county. So when we talk about the state of West Virginia getting what, 700, 800 million, that's not even enough for our county. This is a huge problem, and we have not shown that we have the will to invest anywhere in our nation the kind of money it's going to take to solve this problem. So I don't have the answer for you, but that will is something that we're going to have to change, and we've been hitting it for 10 years here locally, and there's plenty of people out there who've been hitting it for 30 years or longer. I can see some incremental changes here in our community. I hope that the folks that have been doing this longer are seeing some incremental changes nationally, and we may get ahead of this.
Go ahead, no, Zil, come on, put your
and I'm just going to say, I think it's great that we finally have at least some settlement funds that we can look at and assess. But in my experience of what I've seen, throwing money at the problem always doesn't solve the problem. Getting the money now is great. And as Dr. Kilkenny said, you can have incremental change and you can have these smaller things, and that is phenomenal. We will take every percentage point downtick that we can on these issues. Don't get me wrong. But it goes back to the first point that I made about finding trust in these communities. Money now does not fix 40 years of misgivings, right? And so we need to make sure that when we are that if you can get your hands on some of those settlement funds and you can utilize them, that you're doing it the right way and that you're finding the right pragmatic solutions to put the money behind. On top of that, if that's what's coming towards our communities, that's amazing. And I'd love to see it. But it's also, where is the money being directed to? And that is a question that sometimes we get really good answers and sometimes we don't, right? And so it goes back to what Dr. Kilkenny said. That's great that we're seeing incremental change, and I love to see it. That's the only way this is going to go forward. But throwing money at a problem doesn't always necessarily solve the problem.
And I honestly and earnestly agree with you that money isn't the only solution. And
but it's good to have. But it's good to have.
It's good to have. But I think it was either Daffy Duck or Bugs Bunny, and I can't remember which, said strategery is also very important. Strategery is a critically important thing. And if you don't have strategery, you've got nothing. And so I think that that's another part of the question. And we've kind of hit around it, but the Appalachia region mainly And not saying that this is not now gone, it's not an American problem, and I believe it is an American problem. And I believe it is definitely a rural American problem, but I think it really has hit Appalachia in a different way, right? Over the past, you said it, 3 decades. And so, I am often seen as the soft advocate, right? That I'm the advocate of the people and all of this. But the one thing that I think sometimes people get frustrated with me about is when I ask them this question: what are we doing about the people, right, who have been impacted by this for the past 3 decades? We're having a conversation about HIV, which has got 4 decades. We're now talking about substance use disorder issue, which is around three decades. But what we don't want to do is then have a conversation to say, I understand why Representative so and so is mad. Representative so and so has been dealing with this for 30 years. Not just that Representative so and so is just this person who doesn't want to support harm reduction, or doesn't want to have a new MAT facility, or doesn't want to change the rules around OTPs. Maybe Representative so and so has been dealing with trauma around substance use disorder for 30 years. And what do we do about that? How do we start having conversations with the people who are in decision making positions, who have done this and experienced this through a different lens? And when I say that, I mean this: the lens of, I do this for my job, whether I'm an elected official, I'm a public health official, I might be a public health nurse, I might be a community health worker, I might be the trash man. Doesn't matter, right? But guess what? My mama, my daddy, my cousin Bo, or somebody, what are we doing, Dr. Kilkenny, Zill, Eric, about community trauma? Because that's what we got, and we don't like to talk about it.
Well, the city of Huntington has drawn a resiliency plan. The resiliency plan will build into that uh, educational processes for our children, our generations who have not been parented well, who probably, I'm not going to be a governmental official saying reparenting in terms of anything nefarious like that, but from a supportive and nurturing reparenting of a population of people who've suffered an awful lot of trauma and need a little bit of love in their lives, and they need some um, some kind of a loving and nurturing person to build their resiliency so that we can dig our way out of this. The resiliency plan is a 40-year plan, and it is going to cost $1 billion. Uh, how do we then get the support that we need that's on that scale? Because we've got support on a much, much smaller scale that's not going to get the job done.
Dr. Kilkenny, I think you used a great word, resilience. We want to be resilient, right? I think there is a couple of different things. First of all, Tony, great question. I think that there is a serious issue around the narrative that comes with rural, which is that it is where urban and suburban issues go, and that's just where all the problems are. They need our help. These are these issues, and that's just not the case. They are resilient communities that are diverse and have their own intersectional and socioeconomic problems, and they don't need to be patronized. They just need the resources and the help for elevation, and a voice that is louder for the 60 million Americans that live in rural communities. It's just the way it is. And so when you talk about these sort of intergenerational traumas, and whether that is the intersection of race, socioeconomics, health, there's a lot to unpack within that. But the key is letting them lead their voice, right? Let them tell their own stories and elevating those narratives. Because when it is someone from an urban place who's never lived in a rural town, never been to a rural town, doesn't know the difference between Main Street in a rural town and Main Street, New York City, there's big differences in how that impacts and plays into your health. And when your concern is, oh, I broke my arm, I have a 45-minute drive in front of me to the local doc that can set it, versus I can go to a facility that's around the corner, and that's just even basic, emergent care issues, and let alone the syndemic issues that underplay so much of what plagues our communities. And so I think that the keyword is resilient, but innovating,
Hmm.
right? We are innovating. We are doing more with less. And we are finding a way to build off of the resources that exist in our communities, our towns, and the knowledge that is built there. And so trauma informs the future decision makers. And so let's make sure they have the resources and the capacity and the capabilities, and frankly, just the pathway forward to solve those problems. And that comes out of resiliency. And I think that that was just, I don't know, that's a word I stuck on. But I'll add the second point to all of that, which is NRHA did a Faces of Rural campaign that started about 2 years ago now. And it really looks to take the narrative of older, sicker, whiter, poorer, and kind of turn it on its head and show that it is a diverse, innovative, comprehensive, medically sound place to live and exist. And there are ways to get ahead there if you just look at it not as a burdensome opportunity that I should take, but rather a beautiful place to live, work, and thrive.
Might not get Uber Eats, but I swear you get a whole bunch of peace.
Yes, that's right. Absolutely.
How about you, Eric? What do you think about all this?
Yeah, I'll just add that resiliency is a big topic in our upstate region. I'm actually a part of a group called Resilient Upstate, and part of that group is several work groups that are. Um, the one I'm on is working on behavioral health and putting together all the different providers that are available, working with employers, which we're fortunate to have good employment for the most part in our region. A lot of new employers. We have BMW and sort of in the center of our region. So we have a lot of good sources out there for getting information out. And a lot of them actually have their own resiliency type programs going on that we've been able to pull off of. So part of this resilient update, I think we're looking at mid 2025 having a finalized product as far as what our plan is. And I think initially it's a 5-year plan, but it's being run by a group called 10 at the Top in out of Greenville, South Carolina, which basically covers our upstate region. Um, but I've found that the same is true in some individual communities. A lot of the United Ways, we have some really good involved United Way groups in several of our counties in the upstate. Each of them are working on their own behavioral health plan. So we're trying to pull all of that together and sort of pull that into this resilient upstate plan that's being developed. So totally agree with the resiliency piece.
All right, all right. I know we're coming to a close, and I know I've got you three brilliant minds just for a few more minutes here. And I think the resiliency piece, have two follow-ups. One is we've talked a lot about community resilience and community resiliency models. What are we going to do with our elected officials? What do we do with our government officials? What do we do with making sure that we're pulling them in to address some of the things because I think sometimes decision making, sometimes when I see like a crazy or what I think is a crazy or arcane law, I think, who hurt you, boo? Who hurt you? Is what I think. And I think I'll hug you, but I mean, who hurt you? I mean, and so why did you come up with such a crazy law that just doesn't make sense and impacts people's lives so negatively? So I think, how do we talk to them, meaning the elected officials, in a different way? Because I always think we never stop talking. Some people say, there's no point in going to that person. They don't agree with us. And I'm like, I just never believe that. I think that we always should stay in conversation. That's one piece of this. And then my big last, I got a closer for you guys. The closer is what's what are we going to do? Because if we don't address this, we're impacting main streets across every rural community in the United States. If we don't get folks like in care, in treatment, the behavioral health and supports that they need, that's the job of the diner, that's the dishwasher in the diner, that's the guy at the gas station, that's the guy in the mill, that's the guy on the line, or the woman on the line, the woman at the mill. What do we do to ensure that we've got a healthy workforce in rural America? I know. I know. Yep, saved the best for last. I did. That's why they gave me the big job.
Well, our experience in talking to lawmakers is that we need to talk with them and not at them. They don't want to. They don't necessarily feel that we have all that expertise that we think we seem to have, and so just as we meet our clients and can have a conversation with them, we need to meet our lawmakers where they are and see what kind of issues they're needing to address, and then find out in what way can we be a resource for them. And when we've done that, we've had the same impact we've had with other targeted folks where we want to do public health. When we become a resource and a trusted resource, we're a lot more effective than when we are going in.
Yeah, I would just say that that's a key is getting to know those lawmakers, um, sharing real stories in their communities. Uh, they seem to listen and understand when you share those things with them, and it takes time, and continuing to put yourself in front of them over time. I think that makes a lot of difference, and you got to be involved.
And I'll, I'll harp on the building relational point for at least the first question. There's nothing that will beat you showing up consistently, right? A lawmaker, if they know your organization, they know your name, they know your face, they're going to be more likely to lean on you when they have questions. And so, going back to what you said, Tony, about, well, who hurt you to put this policy together? Probably someone who they knew had an idea and talked to them about it. And it's now our responsibility to say, no, that's not bad. That's somewhat bad policy. How can we change that? And so I think that's number one. Number two is not forgetting that they're people just like you and me, and you may vehemently disagree with them on 99.9% of everything they stand for. And then you hear them say, oh, well, I really like telehealth as a model. Oh, I really like this MAT program that you've started. And all of a sudden, you get to build a little bit of a framework, and then you know their dog's name, and then suddenly you're eating dinner with them. And it goes back to the just taking that first step. And the third thing is, don't forget about the staff. Being kind to a staff member, knowing the staff member, that 22-year-old that answered the phone when you called probably has more of an ear with the powerful person you're trying to talk to than you're going to get in the first 3 or 4 meetings. And so, not forgetting them, not forgetting to engage with them, not forgetting to talk to them and treat them like a human being, not just an intermediary between you and a person who has a vote. And then on your second question, about workforce and how do we get these folks back in, and I think that the real answer is just engaging at the beginning, making sure that we're making those 12 crucial contact points as people are growing up about healthcare, what it means to be a health provider, what it means to engage in your community. And I use that 12 number because there's a study that says you need to make 12 contact points with someone throughout their educational career to make them want to come and return to where they practice.
Hmm.
So growing your own models. And then kind of the second thing is, Tony, you said, well, you've got us for these next couple minutes, these three great minds. There are four on this call. Let's not forget your own. And so engaging with those minds in the community to have those conversations and say, how do we put you in front of students? And how do we put you in front of people who might be in suburban or urban areas that may consider coming to rural and practicing for them because they like it out here? They've got family out here. They want to return to their community, and saying, well, let's use the brain trust that we have and put it right on the front. And let's get out there and let's engage with them and try to drag them, not drag them kicking and screaming, but drag them to see the experience that says, okay, you might not get Uber Eats, but have you climbed that mountain today? Because that's what we're going to do together. And so I think that that is a great way that we can engage people. And so I guess the underlying theme of both is not forgetting that you're engaging with other human beings, and they probably are in this work for a lot of the same reasons you are, and just finding that empathetic through line and being able to get better policy and better community engagement out of it too.
You said it. You said a mouthful, because I'm a firm believer in we take them cookies from a local bakery with our logo. We always make sure that we drop off two sets of cookies, one for the member and one for the person at the front desk. Number one, and then the other, and we occasionally will leave them a yo-yo. But I have what I always call the socks policy. The word, we might not agree on anything else, but if I look down and see you got on a pair of fancy socks, I like fancy socks. So guess what? We can talk about that. If you got on fancy watch, I like fancy watch. So we can talk about that. If I see you got baseball stuff up there, it's not my fault you're not a Nats fan. What do you want me to do? I'm a Boston Red Sox fan. But we all have something in common. It's do we take the time to figure out what that thing is, that one thing? It might be you like pickles and I like pickles, but I don't know that unless I keep talking to you. So I want to say this is that let's keep talking to each other, but more importantly, just like I say, I just really believe that none of us want less for the people of rural communities, and none of us want less for the people of Appalachia. We want more. And that is what our jobs are. That is what we do. Not only is that what our job is, I think that having spoken to the three of you today, I know it's what our passions are. So I think we'll get out there and we'll do it. I want to thank you for taking an hour out of what I know are incredibly busy schedules to figure out how to use a new platform, figure out how to do it on your phone, to figure out what's she talking about. Can't be talking to me. I got to get out of here. All of that zeal. Thank you again for taking time. And I think we made 4 rural health conferences in 1 week, each one of them better than the next. So we were very excited about that. And Eric, we're going to send you some info on what we're doing in the settlement framework, and you can give that all to your community partners. We'd be happy to help them as much as we can. And I want to say thank you. Great meeting you, Eric. And I hope you'll be a part of the CEG team, the CEG family. Thank y'all.